Hello and welcome to the Minds on the Frontline podcast. I'm Jeff Lassers, one of your hosts. I'm a professional firefighter, paramedic, educator, and content creator. My co-host today is Mike Mattern. He's also a firefighter and paramedic, but he's also a peer support team expert. In this episode, we provide a clear, practical overview of what happens after a first responder or family member reaches out for help through the Frontline Strong Together 5 program. Many people know about FST5, which offers mental and behavioral health support for Michigan first responders and their family members. What is less clear is what happens after that first step is taken. Once the call is made, questions often remain about how individuals are connected to the right provider, what the first appointment will be like, and how care progresses over time. This episode aims to remove that uncertainty by explaining the process from that first call to ongoing care in a clear and simple way. Joining us in the conversation is Dr. Rebecca Klisz-Hulbert. Dr. K is a psychiatrist and a faculty member with Wayne State University. She also serves as a subject matter and education expert supporting the FST5 program. During this episode, we walk through what happens after that initial call, including how individuals are connected to the right care and what the process looks like moving forward. This conversation is intended to make that process clear and approachable for anyone considering taking that first step. Minds on the Frontline is presented by the Frontline Strong Together 5 program. FST5 offers 24/7 mental health and crisis support for Michigan's first responders and their families. If you or someone you know needs help now, call 1-833-34-STRONG or visit fst5.org to learn more and explore our free training options for Michigan's frontline agencies. Wayne State University administers FST5 with grant funding from the Michigan Department of Health and Human Services. Together we are dedicated to strengthening the health, resilience, and well-being of Michigan's frontline community. Please follow us on social media and enjoy the show. Good morning, Doc. How are you?
Good morning. I'm good, thanks.
Thank you for joining us today. Can you kick us off and tell everybody who you are, what you do, and where you do it?
Yeah, so I'm Dr. Rebecca Klisz-Hulbert. I am a child, adolescent, and adult psychiatrist. I work for Wayne Health and Wayne State University. I oversee child and adolescent psychiatry training for our fellowship program. So those are doctors who are in their very last stage of training to become child and adolescent psychiatrists. I also treat patients at a clinic in Livonia and then do a lot of work with a lot of other trainees in different disciplines as well.
Yeah, it sounds like from you and I talking before, your entry into your world of how you apply medicine, right, through psychiatry, has broadened greatly once you got in the door. So you're like a community type clinician. You're understanding how those communities work. And a lot of that has to do with how the first responders in that community integrate within that, which connected the dots with connecting you with FST5. So what is your affiliation with the FST5 program?
So I oversee the educational piece of the program. So when you guys develop webinars, podcasts, all of those types of things, I look over that data to make sure that what we're presenting to the community is accurate from a medical perspective, that we're conveying the message that we want to convey, that we're using the right terms, and that we're being inclusive of all of the things that we want to talk about.
Yeah, and it's been really nice to not just like Google things when I'm putting together outlines and information, working with these great subject matter experts. You know, one of the reasons I jumped on FST5 was to help develop educational structures and lesson plans and carrying it out. But then there's experts on how you do the peer support stuff. And you bring that great insight onto the clinical evidence-based medicine side to make sure we don't make mistakes and we're giving the best current state-of-the-art information to the people.
Yeah, absolutely.
And that's your role.
Yep.
That's awesome. You know, we're going to tap into that side of you because you're going to educate us today on what happens when people actually decide, I have this thing going on, fine, I'll talk to somebody, I want to enter the system. We have a great call center. It's a crisis and resource center that many people are using. It's increasing usage. And during that time, I think one of the biggest apprehensions is just not knowing what happens after you make the call and schedule an appointment for whatever it is the thing that you need help with.
Yeah, I think that's one of the biggest concerns. People are afraid, right? They're afraid of the unknown. This kind of a stigma type, what a clinician interaction is like.
Exactly.
Once somebody's called the Frontline Strong number, they've reached out, how are people matched with the right provider?
So the first thing is when you fill out that intake form, it's going to have questions on it about where you live, whether you're looking for in-person care or if you want telehealth, if you're looking for a particular type of therapy. Maybe you heard something on one of these podcasts that you think would be helpful for you. If you have a preference for gender of your therapist, all of those types of things. So we'll take a look at that, and then we'll look at our list of culturally competent available clinicians and try to see basically who hits as many of those bullet points as possible so that we match you with someone that has the highest likelihood of kind of fitting your needs.
That's awesome. So it's like a search engine with a human on the other end, identifying, if this person's saying all of this, then you're probably going to be best with this person who's currently available for patients.
Right.
Okay. They've gotten set up. They've gotten their clinician, right? Talk about that scary first meeting.
I'm actually
that first
there.
appointment, right?
Yeah, I got this lady, Klisz-Hulbert. Why she's got so many names? I'm going to go see them,
And kind of what is the goal of that first appointment, and how does that first appointment or first two appointments kind of guide where the care goes from there?
Yeah. So the first couple of appointments really are all part of like the intake process, that initial evaluation. And the biggest goal there is really, number one, to build rapport. So that is hands down the biggest predictor of a successful therapeutic relationship is if you and your therapist have good rapport. So
rapport means I'm going to open up.
Yes.
That's the whole thing.
Absolutely. It means that you have a good connection. You feel comfortable talking to that person.
And not even like I'm deciding. It just naturally will come out with a good rapport.
Yeah.
That's why people become friends. They have good rapport. Right.
And sometimes it doesn't happen on the first visit because depending on how reserved you are as a person, sometimes it takes me a couple of times with a person to kind of crack through their crusty outer shell.
Yeah, totally.
So that's the point of the first couple of sessions, and then also to kind of get the history of what's going on, what are your concerns, what brought you in. So it's really just having a conversation about all of those things.
So really, you're just in the data gathering mode for a while.
Yeah.
Versus like when I go see my doctor, it's a 20-minute onslaught of all the things. They gather the data, they take the blood, they do the stuff, and then results come in, you make a decision.
Yeah.
How you practice medicine in your world, it's a lot slower in the data collection process then.
Our division of medicine is a lot slower because we're reliant on what you tell us. We don't have magical scans. I can't take a blood test for most things to figure out
12% sad.
Yeah.
Yes.
we just don't have that science yet. So we do have to get it through that relationship. And so we have to spend time developing that relationship and kind of getting all of that data verbally.
And I'm guessing that's a majority of your training coming up through the ranks is learning that rapport, because you can have all the knowledge in the world about what you might hear, but if you can't talk to a person, it's a big deal.
Being able to talk to people from a wide variety of backgrounds, a wide variety of things, and about things that you may not be comfortable talking to someone you haven't met before about.
Or at all.
Right.
Yeah. One of the things on the peer support side that we hear a lot of is, after one or two, they're like, I don't think this clinician's for me. And they get discouraged. And they're like, well, this person didn't help. And sometimes they don't go back to see somebody else. Through the program, through Frontline Strong, if somebody doesn't have a good feeling, doesn't have a good rapport, personalities aren't matching, whatever it might be, is there the ability then to have them get another clinician within the program?
Yeah. I mean, in a way, it is kind of like dating and going on that first date. First of all, I do encourage people, usually the first time that I meet them, I kind of set out the lay of the land that, don't expect to feel better after 2 visits with me. That's not how therapy works.
Right.
But if you feel like you're just not connecting with the person or you're just not clicking with the therapist, it is 100% okay to go back to the FST line and say, hey, can I get hooked up with somebody else? Like, this just isn't working for me, their style. I mean, you can't predict which 2 humans are going to be connected and are going to be able to build that rapport. So we are all professionals. That is part of our training. I would much rather you say, you know what, I really like Dr. Kate. She's really nice, but I just don't feel comfortable talking to her. I would much rather have you say that and go see one of my colleagues than me continue torturing you by making you come in and talk to me when you're not comfortable doing it. It's not going to hurt my feelings.
Right. And that's probably a part of your curriculum coming up. 100%. Learning is that you need to be detached in a way that you're available to the person, or you need to not be available to the person.
That's just professionalism.
Yeah.
Yep.
Right. And in this one, it just feels weird because I'm about to tell you about all my feelings and then I'm going to dump you.
Yeah.
Yes.
It feels weird to a human. Like, the pattern recognition of that is like, this feels weird. Mm-hmm. But it's just reminding ourselves that this is a clinical experience and that just you ain't vibing. Just like any, you don't like your dentist. It's no different.
Get a new one.
Go get a new one. no big deal.
Yeah. No, I think, and it's good to hear, right? Because it's one of the things that stops people from coming back. They do the one time and go, well, I didn't vibe with that person. So it's good to hear, and I wanted people to hear that. That's something that we always tell them is like, okay, well, we'll get you another one.
No harm, no foul.
So much of it is about rapport, and if you didn't click with one therapist, that means you didn't click with one therapist.
Yes.
That doesn't mean that therapy's not for you.
Right,
Yes.
right. You could get turned away from anything with the wrong ambassador.
Yes.
Absolutely.
You know, and that's a lot of the things is when you introduce somebody, probably with kids, like you introduce them to a new thing, you don't want to send them to a jerk coach. You want a sweet person who brings them in. You know, a 6-year-old's not going to respond to the screaming like a high school kid playing football. It's a different game. So speaking of which, you know, you're doing this data gathering, assessment, differential diagnosis, could be this, could be that. And through all that dialogue, you start to then formulate what this person really needs over a longer period of time, which could include treatments that are talking treatments or medical treatments like medications. Walk us through how the baseline therapy interacts with the other possible things. Like what does it look like once you got a handle on me?
So eventually, after those first couple of sessions, we'll have like kind of a treatment planning meeting where we'll decide kind of what are your goals, what are the things that you want to accomplish. I may have my own opinions about what
like
I think would be
recommendations,
important.
I think you'd be happier if.
Exactly. And so we'll kind of talk through that and let you lead kind of the conversation about what the goals are. And then we'll talk about what treatments are going to be the most appropriate. And so most of the time, therapy is going to be in there, and that could be different types of therapy. We have EMDR, which we do quite a bit of. Cognitive behavioral therapy is kind of like the mainstay. We've got augmented reality now that we're doing. So all of those different things, and then whether or not medication might be helpful in addition to those things, and maybe referring you to see a psychiatrist like myself if we think that that would be helpful. So we'll talk about kind of all of those options and make a plan and kind of like develop the menu.
Would it be safe to say that you guys have a huge toolbox full of possibilities, none of which means you have to do any of them, none of which are all applying? They're not. It's not a panopharmacy, whatever they call it.
It's not a one-size-fits-all.
No, but you have a big toolbox to say, oh, I got you this, and that, or whatever is going to help you based on what this goal is.
Yes, exactly.
Which may include medications, may not.
Yeah.
And everybody's different, right?
Absolutely.
And so it's good to hear you're treating each person individually and holistically with what's going on with them. And I think one of the big benefits from a psychiatrist, if you also can make, there might be a metabolic issue going on in addition to that, which may be contributing to this as well, and kind of connecting, again, that holistic approach to what's happening.
Yeah, so again, we may be concerned that there's something medical going on that could be contributing, and we'll make recommendations for that.
Or unrelated, and it's certainly not making you better.
Exactly.
You know, let's solve that. Probably a lot of issues going to go away. Yeah. Okay, cool. You know, one of the biggest, I think, barriers subconsciously to a lot of people is, does this person understand the type of person I am? Are they culturally competent, as we like to say around here? Do they get me and my peoples, right? And so I want to get your take on why that is so important first. Why do you think it's so important for people like yourself that could treat first responders and even their family members to really understand what a first responder goes through in general and balancing their life?
Well, I think part of it just goes to even being able to develop that rapport that we talked about. If you feel like you have to explain every little nuanced thing to me, that gets really annoying for you.
Right.
And so if there are things that I already understand because I understand your culture and where you're coming from, that just helps us kind of level up that rapport.
If I only got an hour.
Right.
And you already have a big understanding of when I say I'm riding on a truck and we get to things like that,
right,
whatever it is. That's huge. I didn't even think about that aspect other than just appreciating it. It's just the time saver.
Well, a time saver, but also like it comes back to like then it's not like you explain it to someone once and they understand it. Right. If you haven't experienced it, you don't really fully, truly understand it.
Yes.
So if I have that, then every time you tell me a story when you come in and because you had a bad run or something happened and you want to talk about it, you don't have to go through that all over again.
Exactly.
Well, and
I get you.
And I'll say from the responder perspective of that, you know, when I was going through therapy for some of the stuff that I went through, I was in the middle of a story and then I had to stop my story to then explain something that had nothing to do really with the story.
So they could understand.
So that stuff was flowing.
So you had to explain the context.
Yeah. So like, we had to cut the person, and well, what did you use to cut the car apart? And it's like, what I used to cut the car apart had nothing to do. Let me keep going with what actually bothered me. You know what I mean? So, you get what I'm saying? Like, it's like one of those things where like you've got your stuff that you want to talk about and it's flowing and it gets stopped because you have to explain what a pair of spreaders are or the jaws of life. Or,
so that they can put themselves, say, how would that impact? I get that.
I think that's a big piece. And the other thing that I would add also is that you want someone who's culturally competent because you don't want them to misunderstand when you say things, because sometimes you may make comments that could, in another setting, sound really inappropriate.
Yeah, totally.
But because of the background and where you're coming from, if someone's culturally constant, they're not going to get offended by that. They're not going to.
Yes. That's just how. That's locker room talk.
Right. Exactly.
It's like sometimes we say things to make everybody laugh, and sometimes it's really crazy stuff. We don't believe it, but it's hilarious to watch my friends laugh at the crazy.
You're just trying to get the laugh.
That's it. I don't believe the craziness that comes out of my mouth half the time over coffee at a firehouse. What are you, crazy? Am I going to try to be serious? The world's too crazy right now for it to be serious.
Yes.
So anyway, you get to hang out with us and Scott and Ryan and all these really good first responders. So you've seen how the sausage is made in a lot of ways, but you haven't done a ride along yet.
I have not yet.
And I'm really looking forward to it. I've had a lot of people ride with us over time, very few clinicians, and I think we're starting to see this more and more. And I think if any clinician ever wants to go on a ride along, contact FST5. They'll hook you up, see what it's like. Mike, you've had a lot of ride-alongs. You're a huge, huge advocate for clinicians riding along and understand exactly what the doc laid out.
Yes.
What's your top 3 things doc should do when to be involved in this?
First thing is how you show up. So don't show up dressed up. That's, I would say, the biggest thing.
Yeah.
You're
not going to a business meeting.
No, we've talked about it before. I have had people show up in a suit. Our job, no matter what, we're out doing things, right? So don't show up dressed up. That's going to turn people off right off the bat. Yeah. I had someone show up with a dress and heels, and it's like, you can't do that.
Yeah. They don't recommend that our patients wear dresses.
Yes, exactly. Like, that's number one. Yeah, so, I mean, it also disarms people right away, right? You show up kind of professional, then they're looking at you as, this
HR? Is HR here again?
Yes. But it goes back to the rapport portion, right? You want the person who you can just sit down and have a cup of coffee with and talk, right? So you show up as casual as you can be, or as casual as, the WB will let you,
Yeah, exactly.
So that would be the first one, I think. That would be the first one. The second one, don't be clinical. I've told the story before. We had a gentleman show up. He was one of the ones who showed up very dressed up, even after I told him to show up casual. So casual was like a sport coat and khakis.
Okay?
I should have been way more specific. But he sat at the table. He was very clinical with us. We'd ask him a question. He'd analyze it, think about it, and then spit out an answer 2 minutes later. As firemen, we realized this. We all collectively had telepathy. We're going to mess with this guy.
This will be fun.
And we started rapid firing him, and we short-circuited this guy. I mean, he didn't know what to answer. He was...
He got the special treatment because he didn't,
Yeah.
He wasn't as cool as you.
Yes. But the one, and I always ask the clinicians before they leave, I'm like, what's one thing that you learned today by doing this third ride that you didn't know before, or something that changed your mind about what you thought? And one of the things he said to me, he's like, I don't understand why you guys are so angry people. He's like, you're so mean to one another. And we all started laughing, right? We're all in there. We started laughing.
It's our love language.
And he looked, like befuddled, right? And he's like, well, you were so mean to the gentleman who was cooking, and I didn't think the meal was that bad.
First of all, he's not a gentleman.
Yeah, it's like, well, first off, the meal was that bad, number one. And, number two.
I broke a tooth on a hamburger. It's bad.
Yeah, I didn't know they had salt that looked like zucchini. You know what I mean? Like, that told us right there, like, you're probably not cut out for dealing with us.
You're not going to like us,
right?
You're not going to be able to get past that.
Enough to where he called me like 20 minutes, half hour after he left, and answered all the questions that we asked him at the kitchen. Now that I've
had a moment to reflect.
Yes, exactly. And he's like, I had a lot of fun. Let me, give me a call.
What's your idea of fun, bud?
Yeah. Well, he's like, I'm really looking forward to hearing from you again. I'm like, oh, okay, yeah, sounds good. He's still waiting for that call.
That's nice. That's nice.
Just be yourself. Sit down at the kitchen table, absorb it in, talk to people like we're talking here today. And I got one more story. Okay, it's pretty good. And the reason I'm telling this story is because this person has told the story everywhere. I've seen him at conferences tell the story. I've seen him. So I'm not talking out of class here. We had a clinician who works here at Wayne State. It was the first time I met him. Super nice guy. If you ever met him, he's been on the podcast before.
But you don't have a rapport yet.
Yes, we didn't have a rapport yet.
Yeah.
He comes in, was awesome, hanging out, asking questions, which is another thing. Ask questions. We love when people ask questions to understand us. But he had probably one of the most interesting experiences, I would have to say, for a clinician, but it bought him a lot of street credit.
Okay.
He was riding with us. Now, in our kitchen, underneath our kitchen sink, there's a hole in the wall where the pipe runs, but it runs out to our bay where, like...
So you can see from the kitchen to the bay.
Yes.
And you got a straight shot.
Yes, and where in the bay, that's where the garden hose is.
Oh, nice.
So...
Yeah, you clean the floors, clean the trucks.
Put two and two together.
Yeah.
The joke is you stick the hose
and you wait for a guy to be at the sink.
Yes. So, and we had a probie who was at our station who, this was his first big, I'm going to go get a probie.
Joke, the guy just off probation.
Yeah, day 366.
Right.
Yeah. And so he's out there, he looks through the hole, he sees the probie standing in front of the sink, so he sticks the hose in there. In the meantime, our probie had offered to wash Arash's dinner plate for him. He's like, no, I got it. I can wash my own dishes. As he steps in front of the sink, this guy in the bay opens up this hose, and I'm sitting at the kitchen table. It's in my back, and I can hear the water hitting jeans, right? And this
is like a buttoned-up professional.
Yes. Now, I had no idea
faculty type guy.
I had no idea how big of a deal Arash was here.
It's a big deal.
Right? Yeah. And I turn around and he's just he's like, whoa, what's going on? And I'm just
like a burst pipe.
At first I'm like, oh, did the pipe burst under there? I knew what it was, but I was just so embarrassed. I was so embarrassed that I was like, I can't.
Sir, that's
if I could have reached through the wall at that
bad disposal you're looking under there.
Yeah, I did. I swear to God, I did. I was so embarrassed at first, and he's laughing it off. He's like, and I'm like giving him towels and stuff. Well, the guy from the bay comes peacocking through the door.
Not knowing what he did.
I just played my first prank. And he looks over, sees Arash like patting himself off, and he just turns white as a ghost, right?
Did he leave?
No, I looked at him like, I think you should clean this up. And he just looks at me and goes, right? And I'm like, I am so sorry. I can't believe, I'm sorry.
These guys.
Yeah. I'm like so embarrassed. I'm mortified, right? I'm like, this guy's never coming back, And I was newer here
So you ready for Sunday?
Yeah, I was newer here at Wade State.
We don't have holes in the walls as much as Bloomfield.
But my point was, he thought he was the greatest thing ever. He played it off. He was not an ounce angry about it. He was like, oh, I got a joke played at me at the firehouse.
He can remember that forever.
And he does. He talks about it all the time because he's like, oh, yeah, it felt like I was part of the team, blah. And how he played that off, though.
Guys are like, he's cool.
He's cool.
He got sprayed with water and didn't complain.
Yes.
He can be here all he wants.
The entire crotch area of his jeans is soaking wet, and he's still laughing, right?
Right.
Because it showed, he didn't have an ego. He didn't have a whatever. He was just a human being interacting with other human beings. So the point of that story is that's who you want to be. If you're a clinician going into these third rides, that's who you want to be. You want to be the one with it. There's no ego. It's not like I'm here, because people are worried, are they analyzing us while they're here? No, they're just hanging out.
Yeah.
Right?
They're just waiting for the next
If you're not
thing.
paying me, I'm not analyzing you.
Exactly.
Right. Oh, my God. I like that.
Yes, that's awesome.
You got to separate from work, too, right? Like, you can't just be in work mode all the time.
No.
Having a conversation at dinner, and all of a sudden you're like assessing.
Or when I'm, at school with my kids.
Oh, yeah. That's got to just,
Oh, wow. Yeah, I didn't think about that.
Yeah, she's around kids all the time, and she's going, ADHD. She's just pointing them out.
You're not.
I don't blame
over
you. She's like, oh, that's Billy.
Turn it off.
Billy.
Yep.
Yeah, right.
Yeah.
There you go. That's really healthy, though.
Yes.
That's really good sign of a good clinician that you're not just walking around all day all hyper vigilant like that.
Yeah.
I'd be exhausted.
Well,
that's
the thing. Is like everybody's
right?
like, I just thought they were analyzing us the entire. I'm like, they ain't analyzing you all the time. Like when you leave work at 8 a.m., do you go
off work.
Run medical runs?
Right.
Like, no.
And I'm glad we're bringing this up because I think this is a big part of the conversation for people to hear is that clinicians are people too. They got shit going on. They got all the same human stuff happening all around them. They can just dedicate whatever it is, 40 to 60 hours a week towards this specific skill set, and then they go home.
Yep.
And then they mom or dad or husband or wife or single it up, whatever they do, right? It's just like a guy who goes and paints cars.
Yep.
He paints cars and he goes home.
We're all people.
That's it.
That's it.
That's huge. So understanding that we're all people and everything we've talked about today to go full circle, what's the message you want to give to first responders and their families about entering a system if they think they need help?
The only thing in your way is you. So make that call. We are here to help you. That is our only goal. You just have to take that first step.
Yeah. And like you just said, the only thing to stop you, because there's no cost, there's no copay, there's no nothing
cost,
to
there's
first
no
responders
copay.
and their families.
Yeah.
So literally, it's your decisions are the only thing that can prohibit you seeking additional care. And like we've described today, there's no like you come in, you get a shot, you do that, none of that stuff. It's a process that feels like you're going up a roller coaster really slow, and all of a sudden, oh my God, what are we doing here?
There's not a lot of risk and there's a lot to gain.
Yeah.
Yes.
Yeah.
Yes.
Nobody overdoses on
Therapy.
therapy sessions.
Yeah.
Probably some people go too much and, could spread their own wings, but who knows? That's a whole different conversation. Yeah. All right. Well, thank you very much, Doc. Appreciate you.
Thanks.
Thank you.
Thank you for listening to the Minds on the Frontline podcast. We have more great content coming out soon. Please check us out on YouTube, Instagram, Facebook, X, and LinkedIn. And make sure to like and subscribe to all Minds on the Frontline podcast social media channels. Thank you, and have a great day.